Namaskar. My name is Hema and I'm your host for today's podcast. Today we are going to dive into a very interesting topic commonly unintended, and that are PID. So to talk about this topic, we have a very interesting person with us, a specialist in this topic, and we have Dr. Sagar Bhattad with us, consultant pediatric immunologist and rheumatologist at Aster CMI Hospital, Bangalore. He is the first DM in pediatric immunology and rheumatology for India, certified in bone marrow transplants by EBMT. Director, FPID, Center of Excellence for Diagnosis and Management of PIDs, Aster Hospitals, Bangalore. So a very good morning, sir, and a very warm welcome to this lovely podcast. And thank you so much for sparing your valuable time with us today.
Thank you. Thank you for the opportunity. I look forward to the conversation. Immune deficiencies have been very close to my heart, and for the past 8 years, we have been trying consistently to spread awareness. The work that has been done still seems to be only tip of iceberg, and that is why a lot more patients still remain undiagnosed, and I look forward to the conversation.
Thank you so much, sir. So, sir, can you please give us more insights about what is PID and how common are PIDs?
So the term PID refers to primary immune deficiencies. I'm sure a lot of common public would also be observing this podcast, I believe not only doctors. So to make it simple, I'll tell you our immune system is like an army that fights our enemies, which is infections. Now this immune system is basically composed of several soldiers, and the most important of that is the white blood cells. They fight infections, and now these white blood cells get their instructions from genes. Now unfortunately, if a child is born with a genetic problem where a gene is not properly signaling and these white blood cells are not working, what do you expect? Now these children cannot fight infections, and because they cannot fight infections, they keep coming to our hospitals again and again, and that is what we call primary immune deficiency. Now the word primary here means a group of genetic disorders, and immune deficiency in itself says that there is a problem in the immune system. But in the same go, I would like to say the new term for primary immune deficiencies is the inborn errors of immunity. Now why do we call them as inborn errors of immunity? Because patients here not only have problems with infections, they can have other problems called autoimmunity, malignancies, etc. And I think in the conversation we can take up more about that.
Sure, sir. Thank you so much for giving us a gist about what PID is. But sir, you were just mentioning about children having this immunodeficiency disorders from their genes. So who can be affected by PIDs? Is it just children right from birth, or is there a chance for adults to develop this as they grow into their adulthood?
Now that's a very interesting and a valid question. So when we say these are genetic problems, do only children get affected? The answer is no. Both children and adults can suffer with primary immune deficiencies, and obviously sometimes it looks contradictory that you're saying it's a genetic problem, and why do adults get affected? Because immune deficiencies do not mean a single disease. As I speak today, the classification system says that there are more than 550 primary immune deficiencies.
My God, 550, that's a lot of number.
Yeah. And that is why some of these diseases may be mild and may manifest in adulthood. Some of them are those group of disorders that if patients develop infections, they will respond to antibiotics, but it is not that serious that they will die in childhood, but they keep on suffering for years. For example, one common immune deficiency in adults is the common variable immune deficiency, CVID, and this is grossly underdiagnosed in India. Why? Because these patients won't come to a pediatrician. These patients will go to physicians, pulmonologists, gastroenterologists. So until these specialties become aware of immune deficiencies, unfortunately, these adult patients remain undiagnosed.
So you were just mentioning that it's more than 550 different types. So sir, since you just mentioned that you have more than 550 different types, what are some common symptoms and what are some commonly prevalent diseases, or let's say different types of these disorders for both children and adults, sir?
See, I think to give a prototypical example, I would say the most common symptoms would be recurrent infections. Okay. For example, recurrent pneumonia. Pneumonia means chest infection. So if a child or an adult is having multiple episodes of pneumonia over the last few years, we should start wondering, is there a problem in the immune system? Recurrent ear infections, persistently draining ears, that's a problem. Why should somebody have repeated ear infections needing antibiotics? Then if a patient is needing multiple hospitalizations requiring a lot of antibiotics, then there are children who come to us with chronic diarrhea. Diarrhea means loose motions.
Yes.
And not that these children have loose motions for a day or two, but it goes on for sometimes weeks. And especially if you look at a child who is not growing well, the height and weight does not seem to be appropriate for his or her age. That is a problem. And since these are genetic disorders, then we have to look at the family history. Many times you will see multiple children in a given family are affected. It is very unfortunate. You will see that the first child was suffering and he died without any diagnosis, and then the second child is brought to us. So those that kind of history helps us think that this is a genetic problem and this could possibly be a primary immune deficiency. Now if you talk about types, again if I go to the classification, we have divided them broadly into 10 broad types, but I don't think that is that is helpful for this discussion, because if we discuss each individual type, we would need another hour for discussing each type there. But the broad focus here is that unusual infections, recurrent infections, non-resolving infections, a positive family history, a child who is not thriving well, and then the second spectrum is the autoimmunity. What do you mean by autoimmunity? Our body's immune system is attacking our own body. Now if you have such kind of autoimmune problems at a very young age, again that could be an immune deficiency.
Okay. So you just gave us a brief detail on you mentioned an example, like the first child passed away and the second child is brought to a pediatrician saying that the child has a similar problem as the previous one. So sir, can this be inherited, and what could be the genetic causes for this PID?
Yeah, so as I mentioned, these are genetic disorders. At least the majority of them are genetic disorders, and definitely they are inherited. Now when we say inherited, parents often ask us that both of us are healthy, like the father and the mother. None of our family members had it any time. Why did my baby develop this? So genetic disorders can appear in children when parents are completely healthy. And that is quite possible because the pattern of inheritance is different. Now to make it simple, I'll say these are having Mendelian pattern of inheritance. We have something called autosomal recessive. So these disorders are common in consanguineous marriages. I'm sure you might know consanguinity. Consanguinity is where people marry in close communities, within close family members. In such kind of situations, the chances of having genetic disorders goes up. Okay. Then there are certain group of disorders called X-linked disorders, which are seen only in boys. Now that is one category of disorders. So based on inheritance, you can see different kinds of diseases here.
So sir, you were just mentioning about the different kinds of diseases and that some only boys inherit. So we have various different types of PID, like you mentioned earlier, 550 types. So in order to avoid all this, so sometimes is there any chances that there are early signs that can be detected amongst the family members so that our audience would know, yes, this child could be suffering from PID and they can get the right help at the right time?
So I think the first step to diagnose children or any patient early, I think that's the crux of the matter, is spreading awareness. Right. Like these patients or these children never come to an immunologist. They would go to a pediatrician or to a family physician. So if a family physician or a pediatrician or a physician is aware that yes, this is a serious infection, I need to think beyond usual. Now this child is coming to me for the second or third time with pneumonia. There is something wrong. So these are the warning signs: recurrent infections, unusual severity of infections, multiple family members getting affected. So if pediatricians start thinking on those lines that no, this is not, I see so many patients in my OPD, but I don't see such a situation in every child, oh, this could be a problem in the immune system. And when that awareness goes up, we are just a phone call away. And that is the reality today, that several pediatricians in Bangalore in South India just call us saying that, see Dr. Sagar, I strongly think this is an immune deficiency. What's your opinion? And then we say, yes, let's work up. And then the tests are carried out, and within a week or so, sometimes we make a diagnosis. So that's the reality today.
Okay. So Dr. Sagar, how is PID diagnosed?
Yeah, so diagnosis. I think this question cannot be answered, what you say, in a single sentence, or I cannot say that this is the test you do and the patient is diagnosed. No. Again, the first step to diagnosis is suspicion on the part of physician. If a treating physician or a pediatrician does not think of an immune deficiency, then how is he or she going to ask for a test? So for the last 7-8 years, our constant efforts have been to spread awareness, to make physicians, pediatricians believe that these diseases exist. Just to add to this conversation, they are not rare diseases. Many times people say these are rare diseases. These diseases are as common as 1 in 1,000 to 1 in 1,200 in the common population, in the general population. And that would mean, as I speak today, there are more than 1 million patients with an immune deficiency in India.
My God, that's a lot of number.
That's a huge number, and most of them remain undiagnosed. And what did we do? To increase awareness, we got a small book called Primary Immune Deficiencies Made Simple out. And this is a 150-page handbook, a small book that has been published, say, 3 to 4 years back, and it has been very well received by pediatricians, by physicians, by medical students, because they are the people who are going to suspect and diagnose these conditions. So that is the first step. Now the second step obviously is to send a test. Right. Now many people ask me, is there is there a panel that I can send? Oh, I can diagnose every patient with immune deficiency? No. First, when you suspect, then you have to look what type of immune deficiency are you suspecting. Now, for example, here is a patient who comes with multiple chest infections. I am thinking that there is a problem with immunoglobulin deficiency. So what I would do, I will send a serum immunoglobulin test. Now what are these immunoglobulins? They are the fighting antibodies. Who are producing them? The B cells in our body. Right. The B cells is a type of white cell. So the next step would be, let me send a lymphocyte subset. Let me look at the T cell number, the B cell number. Right? Now, no, I am not thinking of a immunoglobulin deficiency, I am thinking of chronic granulomatous disease. Now, that is another immune deficiency. They come with chest infections, sometimes pus, you know what is called lung abscess, empyema, liver abscess. So, those patients, the test of choice would be something called NBT or DHR, the nitroblue tetrazolium test, the dihydrorhodamine test. Fortunately, in Bangalore, all these tests are easily available and they are very cost effective. Now, if these tests are not answering our suspicion, then there are specialized tests, plus finally there is a genetic test. Now there are again a variety of genetic tests, and that again needs another round of discussion, but to keep it simple, in clinical practice what we do these days is ask for an exome sequencing by the next generation sequencing. Now an exome sequencing is going to sequence all the relevant genes, and then the genetist can report that there are variants in the immunology genes or immune deficiency genes, and that's the diagnosis. So first step, suspicion, second step, immunological test, and third step is the genetic test. That is how we diagnose immune deficiency.
So, sir, you just mentioned about various different diagnoses of PID. But on an average, how long can these take to diagnose various different types of PID?
Yeah, how long? Sometimes the suffering can be for years, for decades. Now again, it depends on the type of immune deficiency. Now there is an immune deficiency called SCID, severe combined immune deficiency. This is a very serious immune deficiency. Children will die within 1 year, maximum 2 years. So there, any delay in diagnosis is fatal. The child will die. On the other hand, I was talking about CVID, common variable immune deficiency. They are diagnosed in adulthood. I today have a patient who is 60-year-old, and she was suffering from the age of 20. That means last 40 years, several admissions, several infections, lots of antibiotics, but no diagnosis. So based on the type of PID, the suffering can vary from few weeks to decades.
So a person suffering for 2 decades, 3 decades, 4 decades, it takes a lot of energy mentally, physically for this person, either child or adult, to go through all this. So they say prevention is better than cure. Is there any way that we can prevent this before the person gets affected with PID?
Yeah, I think that's a very, very important question, because we always keep talking about diagnosing and treating them, but then the families naturally are worried. Yes. Because if one child has got an immune problem, the next question is, will my next child develop it? Yes. And that's a very valid question. And yes, there is a risk that the next child can get affected. Based on inheritance, it can be 25 to 50% risk. But the good news is we can prevent immune deficiencies. Wow. Now, why and how can we do that? Now, number one, if we can get to the genetic diagnosis. Now that's very, very important to get to a genetic diagnosis in a given child. And once you have the genetic diagnosis, in the next pregnancy, antenatally, that means when the mother is pregnant, we can do antenatal tests. We have fetal medicine specialists now who can do antenatal tests like the amniocentesis or the chorionic venous sampling, and then those samples are sent for genetic testing. And if that test says that's negative, you know that the fetus is not affected. And that is how you can continue the pregnancy, and this way we can prevent immune deficiencies.
Wow, it's very nice to know that now we have all these facilities where mothers or parents can take precaution and ensure that the child does not get affected with PID. But sir, let us say that now the child is already born and they later realize that the child, or as they grow into their adulthood, or probably as an infant, he or she is affected with PID. So in such scenarios, what are the general treatment options for PID?
Treatment. Again, as you understand, I am sure that this is not a single disease, so there cannot be a single treatment. So again, the treatment is based on the type of immune deficiency. So you have patients with CVID, the common variable immune deficiency, or the XLA, the X-linked A gamma globulinemia. Now these are B cell group of disorders where there is, I mean to say, immunoglobulins are low, or sometimes there is dysgamma globulinemia. There are immunoglobulins but not working. So the treatment of choice there is IVIG, intravenous immunoglobulin infusions, and these infusions are to be given every month. There is a dose which is based on the weight of the patient, but then these patients need monthly immunoglobulin injections essentially for life. Now if you give them IVIG, their infections significantly come down and they have definitely a better quality of life. Now that's treatment number 1. The treatment number 2 is for certain types of immune deficiencies where there are mild immune deficiencies, we can give them antibiotic prophylaxis. Some low dose appropriate antibiotic that is given over months and years. That's the second line treatment. And then finally, the question is, can we cure these patients? IVIG is a good option, but then you cannot sometimes sustain them for life. And second thing, certain immune deficiencies like SCID are very severe, and if you don't treat them urgently, those patients die. So what is the treatment there? The only treatment there is a bone marrow transplant. So these days, by doing a bone marrow transplant, most patients with immune deficiencies can be cured. Now, sometimes I wonder, many times when I say bone marrow transplants cure immune deficiencies, people come and ask, we heard BMT is for cancers, we heard it's for blood disorders, like why are you talking about bone marrow transplants in immunology, immunodeficiencies? Now let me tell you, where are the white blood cells being produced? What is the factory? The factory for all our blood cells is the bone marrow. And there is a mother cell in the bone marrow called stem cell. So those children who have immune deficiencies, their stem cells are producing bad white blood cells which are not doing their job. So let us change the factory to make it simple. So if you do a bone marrow transplant, from a healthy person you take a bone marrow and you give it to the patient, this bone marrow will now build a new immune system. And once that, correct, producing healthy white blood cells, and that is how these patients are now cured for life. Good thing is, I'm sure everyone has heard of liver transplant, kidney transplant, right? So if kidneys fail, you replace the kidneys, but when you do a kidney transplant, that's a surgery. Bone marrow transplant is not a surgery. That's number 1. And number 2, when you do organ transplants like liver or kidney transplants, the immunosuppression to maintain that organ is given for life. But in bone marrow transplant, most patients will come out of all medicines in 1 to 2 weeks.
Wow, that's a very short span compared to 2 to 3 decades which patients suffer.
Yes. So yes, I think we need to spread this awareness that if we can diagnose them in time without having much damage to their organs, we can transplant them.
So considering that bone marrow is the last resort which person has, so instead of going until the last option, you were just mentioning about immunoglobulin therapy as an option. So how does this immunoglobulin therapy help in managing PIDs?
So see, immunoglobulins are again those antibodies which are produced by our body to fight infections. So normally when I or anybody gets an infection, the body will produce these antibodies. These antibodies will fight those infections and clear the infection, right? So I am sure during COVID days everybody has heard of this COVID antibody. That's also an antibody that was produced against that virus which the body was fighting, right? Now unfortunately there are few patients with immunodeficiencies who don't produce these immunoglobulins. So if they don't produce them, you can replace them from outside. by giving this intravenous immunoglobulin. Now to make it simple, there is a dose. I can just mention the dose here, like 400 to 600 mg per kg per month. So that's the dose. And if you give those immunoglobulins on a monthly basis, now these immunoglobulins will provide that necessary fighting system or fighting fighting power to these patients to fight infections. Now, but immunoglobulins can be given to a select group of patients, like if it is a XLA, CVID, say Wiskott-Aldrich syndrome, there are group of disorders where you can give IVIG, right? But then there are diseases like chronic granulomatous disease where IVIG would not help. So you will have to take a decision on to which patient needs IVIG and which one does not need IVIG. Also, let me tell you, many times IVIG is a bridge to transplant. What do I mean by bridge? Now, I have a patient who is very serious in the ICU. He has been diagnosed to have an immune deficiency. I want to transplant, but that's not the right time. The patient is very unwell. So we give them antibiotics, we give them IVIG.
So the patient is cured?
Yes, the patient is stabilized, not yet cured. The patient gets stabilized and he is nutritionally built. Now he is in a more stable condition, let us take him up for transplant. So many times IVIG helps us to bridge towards transplant. So this is how we use IVIG in day-to-day practice.
Wow, these are some new technologies which the medical industry has come up with so that the people have better facilities and ensure that they get right help at the right time. So sir, speaking of the new age medicine, are there any new treatments or therapies that help in managing PIDs?
So if you talk about new therapies, now since we have more and more molecular testing or genetic testing available, we know exactly what is the immune deficiency these days. Then there are targeted treatments. Say for a particular immune deficiency, I can give a targeted treatment. So that is one thing. I need not bring those names here, say these are rare conditions. There is a condition called APDS, activated phosphokinase delta syndrome. You can give them the PI3 kinase inhibitors. So there is a possibility that we give particular treatment to a particular disease. The second thing is, in this era people are talking about gene therapy, because after all these are genetic disorders. So then people are doing gene therapy, gene editing, but let me again tell you, most of them are under trial. We don't have those facilities yet in India. In the coming decade, I am sure we might see gene therapy for some of these conditions. But as of now, I think diagnosing them early, giving them IVIG when needed, transplanting them and preventing by performing antenatal tests are the four most important pillars of management of immune deficiency.
Right. So thank you so much, sir, for giving us this insights. But Dr. Sagar, I have also another query over here. So you gave us various options from the medical point of view, where the doctors will ensure that they give the patient the right help. But as a patient, as a person, if they are suffering from PID, is there any lifestyle changes that they can adapt to help manage PID better?
Yeah, I'm sure this is a very, very important question, because these patients suffer a lot and they have to make a lot of lifestyle changes, because many times these kids have missed schools for months and years, right? So what kind of lifestyle changes they can adapt to? Number one, I think we most often advise them to drink boiled water. Hand hygiene is very, very important, because many times these infections come because of the food and water, right? Second thing is, if they are exposed to anybody who is having a viral infection, it is better that we follow COVID-like precautions. Maintain social distancing, use masks, not always, but if you are in touch or in contact with a patient who is a person who is having an infection. Right. So avoiding people who have active infections would help. Also, one more important thing is vaccinations. Now we give vaccines to all children generally, but patients with immune deficiencies, certain vaccines are contraindicated. For example, we don't give live vaccines to patients with SCID, with a lot of other immune deficiencies, right? But then there are certain special vaccines that are to be given. Now there is a group of disorders called complement deficiency. There we give the pneumococcal vaccine. So even if you are not trying to give it to the general public, you must give it to them. So by doing these things, we can give them a better quality of life. The other thing is to have a support group. Fortunately, we do have a support group even in Bangalore, where a patient society comes together and patients get a chance to talk to other families. Wow. And that is where they feel connected and they don't feel, oh, I am not the one who is only suffering. And that kind of patient connect programs help. For example, every year at our hospital, we do these patient connect programs where patients come up, talk to each other, and that is how they build confidence that yes, they can fight these diseases.
Awesome. So this is really nice to know that people or families whoever have PID suffering member within them, or let us say their loved one is suffering from PID, they all come together and share their insights and how they feel about each other. But also let us say one thing, sir, when people come together, there might be some rumors or some myths that can be exchanged between people. So according to you, what are some common myths that is prevalent among people in regards to PID?
I think there are several myths about immune deficiencies. At least in the last decade, one myth that has come down is that immune deficiencies are not very common in India. So if you go one decade back, people thought these are very, very rare diseases. This is something that is to be only discussed in textbooks. So that is a big myth. And now that myth is getting washed away because we are spreading awareness and people are getting diagnosed. The other myth I believe people have is that these affect only children. Immune deficiencies don't affect adults. But now we know, we have data, at least in the Western world, the data says 60% of their immune deficiencies are adults. But that's not the truth in India because we don't have much data or much diagnosis. But then that is second myth, that adults don't get immune deficiencies. No, adults do suffer with immune deficiencies. The third myth I believe is many people believe that what is the benefit of diagnosing them? Anyways, there is no cure.
Right.
But that is a myth. We have cure. Most patients with immune deficiencies today can be cured, as I mentioned, with a bone marrow transplant. So these are the common myths, and yes, by talking about these diseases, we can clear such myths.
Awesome. So that's really nice to know that with all such awareness programs, we can ensure the people get the right information and these myths get washed away. But like I mentioned earlier, when people come together, that's when they get to know that okay, their family member also has PID, or probably in their close circle, one might have PID. Now, if after watching this program, or let's say people get generally aware on what PID is, and they suspect that probably in a family or in their close circle, their loved one has PID. So how can they go about this if they suspect this?
So if any of your family member, I must say, we wish that nobody suffers with a primary immune deficiency. We pray for that. But then if somebody has an immune deficiency, the best thing is to get diagnosed early and to get treated. So if somebody is suspicious that, oh, is my child or is some person is having an immune problem, I think the best person is to go and to talk to your physician. Please go and talk to your pediatrician. Express your concerns that my child is suffering with so many infections. Could it be an immune problem? I am sure your pediatricians, your physicians will be very receptive. And then the second step would be, then your pediatrician and you can discuss and then talk to a pediatric immunologist. And that is where immunologists like us would pitch in and see if a given situation warrants investigation. Nowadays, many times we have these seasonal variations. For example, in winters, a lot of kids get viral infections. We have anxious parents coming to us say, oh, does my child have an immune problem? I say, no, your child is healthy. He is getting a few viral infections, which is a part of childhood, it's a part of growth. And we don't do any immune testing. So not that every child who walks in our OPD needs a test. So that is the way to handle it. And so once the pediatrician, the physician or the family is suspecting something, they can reach out to us, they can reach out to a pediatric immunologist, and then we can take it further.
Sure. So thank you, doctor, for giving us all of these insights. But now, speaking from a audience point of view, sometimes not everybody can afford the treatment or the tests. So are these tests and the treatments expensive? Can a normal middle class family afford these tests and treatments?
So yeah, that's a very valid question, because end of the day, who is paying for it is the question, isn't it? Now let me tell you, again, this is another myth that I did not bring up, that immunology tests are costly. Now let me tell you, I will not take any lab's name here. We are not promoting anything here. So NBT test, nitroblue tetrazolium test, is available somewhere between 300 to 500 rupees in Bangalore.
Okay.
Dihydrorhodamine test is available somewhere around 500 rupees in Bangalore. Immunoglobulin test is available somewhere around 1000 to 1200 rupees in Bangalore. So the whole, yeah, it's pretty much affordable for majority of the population.
Yes.
So I think this is another myth that immunology test means, oh, very out of the box, we cannot test these patients. No, even genetic testing, the pricing has come down. Say 5 years back, these tests would cost us around 30 to 40,000. Now many labs offer it at 10 to 15,000. I know it's still a big amount, but then look at the suffering of these patients. I think this amount many times becomes affordable. Now, even if they cannot afford, there are ways and means. there are NGOs which support, there are patient organizations which support these patients, then there is governmental support, and we can definitely diagnose them. And let me also bring to your fact that the government has now come up with the rare disease project, where every patient diagnosed with a rare disease will be given a fixed amount. And under that umbrella, I think if we can diagnose them, most patients now can be treated.
Right. So this is very helpful because most of the population in India would be cost sensitive. So this is really nice to know that the amounts which you just mentioned is pretty much affordable for maximum families in India. Now, sir, instead of going to treatment and then getting it cured, is there any possibility that now let us say a mother or a couple is looking to have a child or they're planning pregnancy and they know that one of them has PID, but they don't want to pass on to the child, but at the same time they also want to ensure they extend their family. Is there any way that you can correct the root cause in the bottom level before it gets passed on to the next generation?
Now see, the thing is, these are genetic disorders, and as I mentioned, we don't yet have gene therapy, right? So we cannot at the moment correct the genetic problem. We cannot fix the genes. But yes, if one of the family members, say father or mother or one of their previous child has had immune deficiency, we can help them. Number one, we can do the genetic test, and once we have the genetic test in our hand, the report in our hands, we can then help them in their next pregnancy. As just mentioned, we can do the testing antenatally, we can see if the baby is affected and then decide accordingly what can be done. Right at this moment, we cannot correct the defective genes, but yes, science is progressing, and in a few years or so, you can see that.
Of course, let's all hope that day comes soon. Yeah. So thank you so much, Dr. Sagar, for your valuable time. It was amazing to listen to this amazing topic and wonderful insights from you. But what would be the key takeaway for our listeners from this podcast?
So once again, thank you. Thank you for arranging this podcast, I must say, because these kind of awareness programs make a big difference on the ground. The key takeaway, I would say, first thing is that primary immune deficiencies as we speak today are not rare diseases. These are in fact common diseases, and they are grossly underdiagnosed. The better term for primary immune deficiencies, scientifically speaking, would be inborn errors of immunity. These patients are out there. We as physicians have the responsibility to not only spread awareness but diagnose them and treat them. If one suspects such an immune deficiency, there are tests that are easily available these days, both immunological tests and genetic tests. And if diagnosed in time, we can treat them, we can cure them, and these days we can prevent such conditions in the next pregnancy. We all have this responsibility, and I am sure we have done quite a good job in the last 5 to 7 years, but then the way is long, and such kind of meetings, such kind of discussions will spread more awareness and make sure all our patients get timely diagnosis. Thank you.
Thank you so much, Dr. Sagar, for your amazing insights and your valuable time that you have spent with us. So that was Dr. Sagar Bhattad for you all, who has given us his expertise on this topic. So if you have any queries, please do ensure you drop in the comment box so that we can respond to the same.